Welcome to Call the Doctor. I am not Dr. Mark Perlmutter, obviously. He has had emergency surgery, and we are really hoping he's going to join us. That's his wish also, and he said that the minute he is so, Dr. Warren said he's on call every night, and he's such a great guy, isn't he?
He is awesome. He's super thorough. He's an excellent consultant and a great resource for our people here at Nash and Rocky Mount. Excellent hand surgeon. I'd let him take care of me or my family, without a doubt.
Well, and he is taking care of my family, and he's taking care of me, so absolutely. Well, tonight we're really happy to have Dr. Alex Warren, who is the medical director of the emergency department at Nash UNC Healthcare, and thank you for being here.
Well, thank you for having me. It's a pleasure to be here.
Well, great. Well, I have to tell you, in the last few years, people speak so beautifully and complimentary about the emergency department. There were some things in the past that have been worked on, and we're going to talk about them and corrected. But I want to let everybody get to know you a little bit first. You grew up here. Your wife grew up here. You've got kids here. You're invested in the community, and that's really important to us. And I think it's important to the hospital to know that our healthcare people choose to be here and be a part of our community.
Absolutely. We've so in the emergency department, when I first came here, there were only 2 doctors that lived in the town, and kind of a group of our APPs or PAs and nurse practitioners that lived here. But our new group is much more invested in the community. We've got, I think we're up to 5 doctors within 20 miles of the hospital or so, and I think all except for 2 of our advanced practice providers are local and within our community. And I think it makes a big difference for emergency care. I think we're a lot more invested in our community. I think we want people to, I won't say enjoy their emergency department stay, just because nobody goes to the emergency department to have a good time, but at least feel like they their problems were heard and were addressed, and that they were appreciative of the care that they get when they come to our facility.
That's exactly what I hear from people, and it hasn't always been so I'm really pleased.
Sure.
I want to mention that we bring in a group of physicians, WEPA. Would you tell how that works, and that they're an excellent group?
Sure. So Wake Emergency Physicians is based out of the Triangle. We're a group of all emergency medicine certified providers. So we staff all of the Wake Med sites, UNC Johnston Health, which is both Smithfield and Clayton, and then Nash UNC, which is here in Rocky Mount. All in all, it's about 140 emergency providers or so. And each site, so Nash, for example, we have 14 doctors that are dedicated to our hospital, and probably about the same number of APPs. I'd have to think about that for a little bit.
You want to say what APPs are?
The APPs are physician assistants and nurse practitioners. And so even though we're part of a larger group of all emergency providers, we have our dedicated Nash group, which again, I think that makes a difference, because each provider's working 16, 15 shifts a month at Nash. They want to be happy to come to work. They want to know that they're doing a good job and that their colleagues are doing a good job. So I think it's an excellent group, and we are one of the few democratic provider groups for emergency medicine that's left. And what that means is that we are provider run, as opposed to a lot of emergency medicine groups are corporate run. And so they're more interested in how to generate the most money, how to cut margins, staff emergency departments as slim as possible. Whereas Wake Emergency Physicians, if anything, we have more than enough providers on shift to take care of however many people come to the emergency department to be seen. And I've been here through other contract groups that were not so friendly to providers, and the morale of the team is tremendously different, which I think translates to the difference in the patient experience, because we're all happy to be at work and we're happy to be there to take care of folks. Whereas previously, I think we were a bit overworked and tired,
and stressed.
And it's kind of hard to provide a great experience when you're constantly running on empty.
Dr. Horn, I think people would be really surprised that we have the largest number of emergency department visits of all of the UNC hospitals.
So you mentioned I was from here, and when I grew up, I never would have envisioned myself coming back to Rocky Mount. Not that I have anything against the community or anything, but I always just thought I wanted to be at a busier hospital, a hospital that had more acuity and pathology. Acuity meaning like patients that are really sick or really injured. I came to interview at Nash primarily to appease my mother, who really wanted us to come take a look.
And your in-laws too.
Primarily my mother. I mean, not that my in-laws didn't want us to come, but my mom really wanted us to come back. And I remember interviewing with the director at the time, who's still with us, Ken Moore. He's been in our ER for probably going on 20 years plus. Forgive me if I'm wrong, Ken. He was telling me about how busy the place was and how sick the patients are, and it has not let me down. I have never left a shift here without feeling exceptionally fortunate to work here because of the amount of patients that need help and the amount of patients that truly need emergency department care. We do pull the largest volume in the entire UNC system. We're not the busiest ER in the entire state, but comparatively, you're looking at like Rex and UNC Chapel Hill and some of these other big hospitals that you would really think would knock Nash out of the water, if you will, and it's actually the opposite. We serve 5 counties. I don't think people realize, with Nash's location on 95 and 64, 50 minutes from Greenville, an hour from the Triangle, Wilson County, Halifax County, Franklin, Nash, and Edgecombe, they tend to come here for care. And a real tribute to our executive team and recruiting team. I mean, we've really developed a specialty group that allows us in the emergency room to take care of that many people really fairly seamlessly. I think it's really important to give a kudos to all of our specialists, talking about Mark being in emergency surgery tonight. When you come to the emergency room, you see an emergency doctor, but we may not be able to fix you. We may need the hand surgeon or the urologist or ear, nose, and throat doctor or whatever specialty. And when I first came here, we were a lot of our physicians in the community were aging out of practice. And in the last 7 years, we've brought on multiple new subspecialists, both in the medical and surgical fields. And if anything, it just makes my job easier because I have more friends to call when I need help, as opposed to having to call Raleigh or Greenville or Chapel Hill or wherever to try to get that help that patients need.
I'm prejudiced for UNC, but don't you think having the UNC support with recruitment and just having that as part of our name helps people who historically might have gone east are coming west now to us?
Oh, absolutely. And I think one thing that I don't think is very well known is the hospital medical record system is integrated across all of the UNC system. And so when I do need to pick up the phone and call someone in Chapel Hill or Rex, we're looking at the same medical record. We're not having to fax things or take things by how I'm describing them or anything like that. We're actually looking at the same labs, the same x-rays, CAT scans, and we're able to make decisions that really impact patient care without necessarily having to send that patient all the way to Chapel Hill. And I think patients feel that difference. I think they feel like they're getting tertiary level care in their home, and I think it makes them feel comfortable. And on that note, I think it helps with recruiting specialists as well, because I think the UNC name it's a national name. It's not like just a North Carolina name. I think you could go to California and people would know who UNC is. And,
well, I hope so.
I'm partial to NC State, I got to say, from a sports standpoint, but the Tar Heels probably put us on the map from a basketball standpoint. But the healthcare system in and of itself is a power as well.
Oh yeah, the various schools, like whether it's Lineberger, and now we have a branch of Lineberger there. One of the things that people might not know, and this we're kind of jumping around a little bit, but we'll cover everything, folks, don't worry. Strokes. I had a friend who had a stroke, and he came there immediately. And so basically he has very little residual effects of it. Talk about the importance of that and the fact the neurologist whom you have right there ready.
Sure. So when you come, well, let's start even before that. I mean, just from a public health kind of standpoint, if you ever develop, one side of your body does not work, whether it's motor strength, so the ability to move your side or feel your side, or form words to speak normally, or even lose part of your vision, that's not something to sit at home and wait and see if it goes away. You have about 4.5 hours from the time that your symptoms begin to come to emergency departments to receive care, and you would be seen immediately if you present to the emergency room with those types of symptoms, because we're going to try to expedite your care to get you to not only the neurologist. We partner with Duke Telestroke for neurology care for acute stroke, but it's to get the important diagnostics, a CAT scan to be sure that you haven't had a bleed in your head and that it's truly a blockage. And then some of the lab work that we have to do to determine if you can even receive the therapeutics. But then if you're within that 4.5 hour window, we can give you a medicine that's a clot buster that basically will hopefully open up the blood flow to your brain and help your, whether it's motor weakness, numbness, speech difficulty, hopefully it goes away. And there have been multiple studies that have shown that the earlier you get that medicine, the more effective it is, and definitely the safer it is. So absolutely, that's a very important thing from a community health standpoint, to be sure that you're aware of the symptoms that you're having and what it could represent. And it's not a decision that we make alone as emergency providers. Like I mentioned, we partner with Duke Telestroke, and that's a group of neurologists, which are brain doctors, brain specialists, that only do stroke care. And so they help us through kind of a FaceTime kind of interface, where they evaluate the patient with us. They evaluate the imaging that we do and the labs that we do to help us determine that number one, the patient would be eligible for that treatment, but then also if there's treatments that are not eligible at NASH that could only be done at a tertiary center like Duke or Chapel Hill, and then they help us transfer the patient. If you had a big enough stroke that we couldn't take care of you at NASH, or you needed a procedure to not only do the clot buster to dissolve the clot, but to have a similar procedure like a heart catheterization, where they would go in and open that area up to the blood flow to the brain. And that's time is tissue there, because even for those procedures you only have about 22 hours to get those done. And if you think about that, you've got to recognize your symptoms, present for care, have the diagnosis made, get transported to a tertiary center, get into their interventional suite, and have that done all within the 22-hour time frame. Which actually brings us to another great point that I think is important for the community to know, is we have a helicopter stationed right at NASH.
We do, yeah.
And it is solely for the purpose of stroke patients, trauma patients, heart attack patients that if our cardiologist cannot take care of them, and they may need like coronary artery bypass or open heart surgery, and that helicopter facilitates getting you to those higher levels of care much quicker than an ambulance leaving from Raleigh, coming all the way to Rocky Mount, picking you up and going back. Because believe it or not, the ambulances don't ride at 100 miles an hour. They tend to ride at about 65 or something. I think they have a regulator or something.
And the helipad is right there, right behind the ED.
Yeah, it's literally, we could throw a football from the back of the ED and hit the ambulance pad, or the helicopter pad.
And put them on it. Well, I want to say that we have got just really wonderful ratings too. We're in the top 5% of clinical excellence for stroke care, orthopedics, critical care. The role for surrounding counties, as you mentioned. We've got a few minutes before we have to take a break. I want to talk about emergency services, because a lot of the things, chest pain, high fever, seizure, severe pain, traumatic injury, and so forth, when somebody's thinking about coming, How do you determine if you go to the ED? And it used to be ER, folks. So if you hear us saying ED and you're wondering why, it was ER, and it had the TV show about ER. But now it's emergency department.
We are a department of the hospital. We're no longer just a room associated with the hospital. So absolutely, I won't say we take offense, but it's definitely a sensitive subject for emergency medicine providers.
I'll tell you what, let's bring up this thing, and we can talk about that as some of the things. So let's bring up the first, when to go to the emergency department, and we'll get Dr. Warren to kind of talk about some of those and the importance of, if you have any of these happen, why don't ignore them.
Sure. So, to break through some of those, so chest pain or pressure, that's a very difficult symptom for us. It's one of our most common presentations, but the most important thing is you cannot ignore that, because that could be a sign that you're having a heart attack, blood clots in your lung, a collapsed lung. One of the aorta or the arteries that comes off the heart can actually tear. So these are all life-threatening emergencies that, if they're not diagnosed within a fairly quick amount of time, you could end up having significant debility, meaning that you would lose your quality of life and ability to function normally, or even expire or die. The next one is severe head injury. Anytime somebody hits their head and gets knocked out, it should be an absolute no-brainer, not to put a play on words there, that you should come to the emergency room and get evaluated.
If they lose consciousness, you mean?
If they lose consciousness, yeah.
What about not quite that bad, if they hurt really badly? I mean, shouldn't they come then too?
So absolutely, if you hurt really badly. And then the other thing to really keep in mind is for our population that's on blood thinners, or the stronger antiplatelet medications. So Plavix, Xarelto, Eliquis, Coumadin being the most common. All of those medications would put you at a higher risk, that even if you didn't lose consciousness, and maybe even you didn't even hurt that bad, but if you hit your head a decent amount, you could have bleeding on the brain that would need to be intervened upon, or at least treated in some way, even if it's just reversing the medication that you're on for a couple of days. But absolutely, any head injury needs to be seen, but I'd say 100% if you lose consciousness, 100% if you have severe pain, and 100% if you're on any of those medications we mentioned.
And it could be a subdural hematoma too. I know Liam Neeson's wife died of that, and that was just...
When those typically are slow, which is why those are the ones that the old wives' tale is, if you hit your head, don't go to sleep. You need to stay awake for so many hours. And that's for the subdural hematomas, because that's usually a slow bleed around the brain as opposed to within the brain. But over time, that bleed takes enough space that it actually puts pressure on the brain, and then you just kind of go to sleep and you don't wake up. And that's something, these types of bleeding on the brain, they're very easy to detect on CAT scan, which is something that we have readily available in the emergency department. And most of them are actually, I won't say easily fixed, but they're at least treatable if they're recognized at an early stage. So very important. Yeah, very important. And these are definitely some things that I would call 911. I know people don't want to overburden our ambulance system, which our ambulance crews do a great job. Both Nash and Edgecombe County being our two largest EMS services, and they do a great job of not only getting patients to us, but helping us to recognize some of these things on this list, so that the patients are brought directly to the back, or if we're so overwhelmed with patients that we can't get them in a room immediately, at least help us identify the patient at the back door so that we can get the test started, so that their problems are recognized as early as possible.
Okay, heavy bleeding, trouble breathing?
Yeah, it's heavy bleeding, that's anywhere. If you're a dialysis patient from your dialysis access, or if you've cut yourself and you can't make it stop bleeding with simply applying pressure, sometimes we need to either cautery the area or put a stitch across it to stop it from bleeding. But there's an old adage in emergency medicine, it's a bit of a cynical adage, but all bleeding stops eventually, but nobody wants to be on the end where it stops when you run out of blood. And that can really happen. So if you're at home and you cut yourself and you just can't make it stop, you need to come see us.
Call 911.
Call 911. And actually, the paramedics do they actually usually stop the bleeding long before you get to the hospital. They have combat gauze, which is a type of gauze bandage that has a chemical in it that helps our body clot. And then they have a number of kind of tourniquets and pressure dressings and stuff that they can put on folks to help them out really quickly. And trouble breathing goes without saying, especially after all the COVID. I think everybody knows to kind of come to the ER if you can't breathe. Trouble breathing can be from anything. It can be from asthma. You could have inhaled too much Clorox while you were cleaning or some other chemical. But obviously, if you're having trouble breathing, you need to get on a monitor so we know if your body's getting enough oxygen and fix whatever the problem is. And things as simple as inhaling too much Clorox, we can treat that. You'd think it's almost like a burn, but you get on the right inhalers and right steroids, we can make you feel better within about an hour. So it's a heck of a lot better than sitting at home and struggling to breathe all night while your lungs recover on their own.
Absolutely. And we are going to take a break, but let's just finish this page before we do. Severe vomiting or abdominal pain?
So severe vomiting, you're worried primarily about becoming dehydrated, but when you throw in severe vomiting plus abdominal pain, the sky's the limit for pathology there. You could have bowel obstructions, you could have infections in the intestines,
food
poisoning. You can have infections in your bladder or kidneys that can cause abdominal pain and vomiting. And all of these things are usually something that needs to be recognized so that treatment can be started so that you don't become dehydrated, you don't become septic, or some of the other bad things that can happen. And so hopefully you can go home from the emergency department as opposed to having to stay in the hospital for a couple of days, which a lot of those things that we just listed, if you stay at home and try to home treat yourself, you'll just get worse over time.
Yeah, especially the dehydration too. I mean, if you're throwing up and whatnot, then you're going to run out of fluids if you can't intake any. Blurry vision?
So blurry vision, that can be a sign of stroke like we mentioned earlier, but the other thing it can be is there's a number of problems that can happen intrinsically to the eye. Blood flow to the eye can be disrupted, whether it's the blood flow out of the eye or in the eye. And then there's various types of problems that can happen with your retina, which is actually the part of the eye that is responsible for our seeing. And these are things that if they're not recognized fast, you can go blind.
If the curtain drops and you can't see, I've heard that.
If the curtain drops, your retina is tearing off and it needs to be fixed.
Very quickly.
Very quickly. For sure within 24 hours. I think most ophthalmologists will tell you within 24 hours, but most of them will fix it within like 2 or 3.
And it's scary. And people, I've heard ophthalmologists tell me that people have waited. And that's a terrible thing to do because then it can't be fixed.
Yeah, and once the eye kind of, once it reaches a certain point, it's not like the liver or some of the other parts of the body that can regenerate or heal. The eye, once it reaches a critical point, it's done. And, I don't know about you, but I would be mighty afraid if I had to live in a dark world.
Oh, same here. I remember going one time and I said to an optometrist, I said, I feel like almost like an ice pick is sticking in my eye. And he said, oh, you have ice pick syndrome. Have you ever heard of that?
I have heard of it.
And I said, well, that's awful. And he said, well, no, it's fairly common. And I thought, well, it doesn't feel common when it happens to you.
No, so. Thankfully, knock on wood, I've never seen anybody with that, and I hope I don't, because I don't know what I would do to help.
Well, it went away pretty quickly once he said, it's okay, it won't hurt you. And I said, well, yeah, it has, it is.
That's one of those benefits of having all those consultants to call, though, because when I get something like that, I'll call them and say, hey, this is what I got, and they help me out. And maybe it's reassurance, maybe it's certain eye drops or something else that we can do to help you out.
Okay, dizziness and loss of consciousness and broken bones and deep wounds.
Yeah, so broken bones and deep wounds I think would be something that Dr. Perlmutter would want me to talk about for sure. So anytime you have a broken bone, it needs to be addressed ASAP. If it's just a little crack or something, we would put you in a splint without doing anything. But if your forearm is angled or potentially you've got a dislocation of one of your joints, these are all things that need to be replaced or reset in a quick manner. And
why?
Well, number one, your body will heal most fractures without surgery, and that may be something Dr. Perlmutter doesn't want me to say. But if it's done correctly up front and the reduction sets the bones in a normal alignment, or if it's dislocated and we put it back, a lot of times your body will take care of things if it's done quickly. If the body has a chance to start healing when the bones are in the wrong orientation, a lot of times that leads to having to have surgery to re-break the bones and put them back in the right spot, or maybe it's maybe you still need a surgery, but it's a much simpler surgery, like just a plate with a screw, as opposed to having to have like multiple plates or multiple screws or multiple cuts to do the fixation. So I would say the other thing about Nash is our orthopedic group is exceptionally responsive, which is why he's in surgery right now. But he and his partners with both Carolina Regional and Nash Orthopedics, they come help us in the emergency department if we can't get it right. But I'd say well over 95% of orthopedic injuries we're able to take care of in the ED by ourselves, and then they get you into the office the next day.
And now on the campus by the hospital, you've got ENT, you've got OBGYN, you've got orthopedics. I mean, you've got a lot of people right there close by too, don't you?
Well, yeah, and even if you think about urology, is probably as far as we get, and they're only probably a mile or two away, tops. But we've got just about every specialty represented at Nash outside of maybe one or two, and they're all basically on our campus or within a stone's throw, which is...
And certainly Boyce Willis too. I mean, great providers there. Dizziness and loss of consciousness, let's do that and then let's take a break.
So dizziness and loss of consciousness, we hit on some of that with head injuries or potential stroke, but then with dizziness you worry about some of the cardiac problems or heart problems. Is your heart beating out of rhythm? Is it like atrial fibrillation or atrial flutter or some of the other heart conduction or rhythm disturbances? And these are all things that they may only cause you to be dizzy right now, but eventually you may pass all the way out. Eventually they can lead to other like cardiac arrest and more serious problems. So these are symptoms that you need to get addressed early before you develop any of those more life-threatening processes that can develop. So.
I hope I don't have to come, but boy, you sure do make me feel good if I ever have to come there. So,
well, thank you.
We're going to take a break and we'll be right back. And by the way, if you want to call in with any questions, Dr. Warren would love to answer your questions. So stay tuned.
What the community paramedic program is a program that sends paramedics out into the community to help patients after discharge.
It connects the dots for them. He provides education and also to proactively take care of our patients. So evidence-based practice says that if the community paramedic sees the patient in the home, they're able to decrease the readmission rate. It just decreases the burden on the healthcare system.
Taking chronic patients, it takes a toll on all the providers, from the ED to med-surg nursing to the dispatch call takers. Some of the things that we do when we go out to a residence is we will do vital signs. We will do medication reconciliation, where we take and look through all their medications. We answer phone calls. If patients have questions, we can help walk them through their needs. We can communicate with their doctors. Sometimes they'll make medication changes right over the phone, and that'll help keep a patient out of the hospital so they can be, at home and healthy. We do lab draws for patients who can't get in and out of the house. We do coronavirus vaccines. We've seen patients who were our high-risk readmitters who had been in and out of the hospital get their diseases under control. Most of the time they get a better understanding of their disease process, and they're able to live a healthier life, which is what we want ultimately, is for the patient to be healthier.
Well, after he gets to the routine, he answers all my questions. And he takes the time. I mean, those heart doctors, they whiz in. They're so rushed. And you go, and they're gone. But Till takes the time.
I'm so lucky to have Mr. Till in my life, because If it weren't for him to come back and check on me and make sure that that I'm stable and able to go to my doctors and see what kind of meds I need, I won't have nothing.
He's a blessing. He really is.
So being able to connect with patients on a personal level and just talk to them and let them know that it's going to be okay and that you can be healthier, you can resume a good quality of life. I think that helps the community as a whole.
This is where the public would benefit if they had more TILs out there.
Honestly, I would really like to have at least 10 community paramedics to be able to cover our patients.
The more cars you have, the more people you can help, the more lives you'll save.
And we are back, and Dr. Mark Perlmutter, who is your normal host, was in surgery. And apparently, Dr. Warren, he got tied up, which we're not surprised, because he's never one who will walk away. If somebody needs him, he's always there, isn't he?
Absolutely, absolutely. He's one of the easiest people to talk to, and he's always there for his patients.
Absolutely, and he's with Carolina Regional Orthopedics. We were just talking about the orthopedist. Do you call them orthopods or orthopedists, or what do you call them?
Everything.
Everything.
I think they're called orthopods more within the hospital.
Oh, okay.
I think orthopedists is probably what they're referred to more in the community.
Let's talk about the ED, and we're going to talk about the pediatric, a great sport, pediatrics. But before we do, I want Lee, if you'll put up the triage model, because I want Dr. Warren to kind of walk us through that so people know we have the lowest number of, for like-size hospitals, of people leaving without being seen. And it used to be people get frustrated and just leave.
Yep.
But now it's 2.4%, which is almost unheard of to be that low.
Well, it's especially unheard of with the current kind of medical climate. You know, with the COVID-19 pandemic, hospitals all across the country have struggled with nurse staffing, tech staffing, patient volumes kind of being up and down and all over the place. And what we've seen historically before COVID, 2% was kind of the national or the industry standard for what we wanted. But what we're seeing is most hospitals are much closer to between 4 and 5%. And those are the ones that are doing really well. So by being at 2.4%, we knocked it out of the park. And some of that is based on the graphic that's on the screen there. And I don't know how well it came across for the viewers out there. Is that one on the right for them? Or?
They can, when they're looking at like we are.
Like we are. Okay.
So if you want to read it off this big one.
So if you look at the model on the left, that's the more direct one without the green and the red. That is more of the traditional patient encounter in the emergency room. If you went back 7-8 years ago, that's how 90% of ERs function. You know, you would come into the ER, you would register at the front desk, you would see a nurse who would do a triage assessment, and then you would wait until you were seen in a room. Now that room could be in various areas of an ER depending how big it was. Maybe the lower acuity or the less sick would be in like a fast track or minor care, and the sickest of the sick would be in a more high intensity or acute area of the ER. But what ERs across the nation are doing to basically address getting care to their patients as fast as possible, recognizing sicker patients who maybe would be missed in the traditional triage process, but also trying to take care of as many people as we can with as few resources as we can, have moved to the model on the right, where you're going to come in and register a nurse or a paramedic, depending on which system you're in. And at NASH, you're going to see a nurse that's going to help with this. is going to at least talk to you briefly to be sure that you're not having a stroke or a heart attack or something where you need to just bypass everything altogether and go just get put in front of a doctor. And then you're going to basically, after that step, you're going to be moved into a triage room where you're going to see a triage nurse, very similar to the other process, but you're also going to see a provider. And at NASH, our advanced practice team that we mentioned before, the physician assistants and nurse practitioners, they staff that area in turns, and basically you're getting, it may be a brief exam and a brief history. It's definitely not as thorough as you'll get in the back, but you're getting a lot more than what you would get with the typical triage process. So then you're getting your blood work, your x-rays, your CAT scans, ultrasounds, whatever else ordered out of that area. And then most likely, assuming that you're stable, which you are to get to that point in the process, you're going to go back to the lobby where you're then going to wait for those results to get to filter through. And it's important to realize that even though you've seen a provider and you've gone back to the lobby, we have started your care. And when labs are ordered or x-rays are ordered, they don't just sit there. All of the providers are constantly looking at the waiting room to see if somebody has abnormal lab values or abnormal imaging that would need to move them to the top of the list. Because when you're seeing 65,000 patients a year, sometimes having 30 patients check in an hour, it's impossible to get people in front of a physician in a room as quickly as we would like. So we basically use this process so that we can get their workup going, and if they're able to sit in a chair safely, then that allows us to see many more patients than what the rooms we have at the same time. And then we also do, the provider in triage will order things like IV fluids, IV pain medicines, IV nausea medicines, oral medicines, to try to help make you more comfortable while you're waiting, if you're having pain or nausea.
And bring that out in the waiting room and hook up an IV to them?
So they'll usually do that before you leave that kind of triage area, but they do it kind of in tandem. So the provider will see you, the nurse will be doing the triage, and usually a medic will be working on you at the same time. And then the provider is kind of saying, let's give this patient medicine for nausea. And the paramedic's going to go get it while they're taking the patient back out to the lobby and give it to them on the way. And that way, hopefully, they're more comfortable while they're waiting. Obviously, sometimes when we are particularly busy, not everybody in the lobby can be 100% comfortable. But at least that way, we're getting through those people and getting as many people in front of providers as we can.
And when you think of the quality that's there and the fact that as numbers come up on screens, you have people watch them, so if there's a true emergency, you can jump on it right away.
Oh, absolutely. If you find somebody that, let's say, needs a blood transfusion, or let's say they checked in with chest pain and their initial EKG, which is what we use to look for acute heart attacks, is normal, they may go to the lobby even though they have chest pain, but somebody's going to be watching for those lab values and that x-ray to tell us if there's something bad going on. And so let's say we put you in the lobby and it took 45 minutes for those blood markers to come back. Well, then if they were abnormal, we're going to say, let's call Miss Kitchen back immediately. And so even though some of those symptoms we talked about earlier are signs of very bad things, you still may end up waiting in the lobby while those initial tests are going on. But it's exceptionally important to know that you're not waiting in the lobby with nothing happening, and you're not waiting in the lobby with no one watching you. Not only are there paramedics that we employ and nurses, but you also have the providers in the back looking at the workup as it's coming resulted. So there's many eyes trying to keep an eye on everybody that we have in the ER at one time.
And if it's heart, then you've got the cardiac unit right above the ED.
And that goes to the specialists. We have cardiologists at our fingertips 24/7. So if you need any type of cardiac intervention, whether it's a pacemaker to help your heart rate stay up in the normal rate, whether it's a stent to try to open up a blocked artery, These are things that our cardiologists are able to do for our patients 24 hours a day, 7 days a week. So
And that's really amazing that we have it staffed, that interventionalists are there all the time.
Absolutely. So I came in 2015, and when I first came here, we were giving clot busting medicine like we were for stroke, for heart attacks. And in all honesty, that is really outdated medicine, and it was outdated in 2015, but it was the best we could do. So now with the cardiologists that we have, you are really getting state-of-the-art care, the same care that you would get if you presented to any hospital in Raleigh or Greenville or Winston-Salem, some other big community, here in Rocky Mount. So.
And I love that, not having to leave.
Well, and keep in mind our cardiology group, they are a lot of them are
UNC professors.
Yeah, thank you. Are UNC professors, and they some of them work a third of their time in Chapel Hill.
And they even teach there. They teach intervention strategies.
And so by being here, you're not getting like an inferior cardiologist. You're getting the same cardiologist that will be doing your high-risk procedure in Chapel Hill. It's just their turn to be in Rocky Mount.
You mentioned, Dr. Warren, the helicopter. That's a UNC helicopter. And what difference has that made to you to have that sitting there on our campus on go all the time, 24 hours a day?
I think it's a huge benefit to us, because typically when you so there's two types of three types of patients that are going to end up on a helicopter. One's going to come from the Women's Center, so somebody that's delivered a baby that's sick. One's going to come from our intensive care unit that maybe has decompensated while they're here. But the vast majority of them are going to come from the ER. They've come into the ER with whatever their complaint is, and they've been diagnosed with something that we can't take care of at NASH. And a lot of the things that we can't take care of, because we're really able to take care of most things, are exceptionally time sensitive. We mentioned the artery tearing off the top of the heart. That's something that's universally fatal, meaning that you die from that unless you have surgery. And you have to have surgery like as soon as possible. Brain bleeds. Those are things that, the reason you don't want to go to sleep with a subdural is you don't want to give it more time to accumulate. So you sure want to get to the neurosurgeons in Chapel Hill or Rex or wherever as fast as possible. For the patients that are injured in trauma, whether it's a car accident on I-95 or any other type of trauma, getting in front of a trauma surgeon as fast as possible saves lives. And it's about an hour roughly to whatever tertiary center you want to go to from ground, but it's about 12 minutes by air. So
12 minutes?
That's a huge difference.
Gosh.
Think about if you're bleeding, something's tearing.
And they're waiting for you when you get there. I mean,
we actually have we call it our ready button, and it's literally a big red button in the nurse station that we hit whenever we recognize somebody that needs to fly out, and it starts a series of actions that basically gets our helicopter on alert, where they're checking the weather to be sure they can fly. They're already starting to be sure that they're gassed up and ready to go. And a lot of times they go ahead and move, because they're in like a little holding area on the back side of the hospital. They'll move their helicopter to our helipad just so that they're not wasting any time once the patient's ready to go. Because there's a lot of moving pieces, but it's pretty interesting how streamlined it is. And I think it's kind of funny that we have a alarm
big
button.
red button.
Yeah, I mean, it's literally a big red button.
Yeah, I had never heard that. That's really interesting. Why don't we take one quick break, and then we come back. I want to really talk about the pediatric emergency services, because I want people to know the great care. I mean, we've talked mostly about adults, but you can really take care of kids at our hospital too. So we'll be right back. Very good.
The foundation plays a really integral part in the health of our community. They help with the health system identify those needs and gaps.
As a physician here at the hospital, we utilize the foundation to offer a lot of supplemental support services that may not be covered by insurance, but are fundamental and instrumental to the health of our patients.
The foundation may be able to assist with some of the financial burden that the patients experience outside of the hospital, such as rent assistance, utilities, and some medication needs.
The inpatient food pantry. The foundation has been instrumental in raising money here, and it's meeting a critical need that many of us don't know about.
Getting them the food and the help that they need, especially from the food bank that we've implemented, has been really successful, and our staff have been really engaged and excited about being able to provide this service to the community.
Their support of our cancer center and services, the heart center, the women's center, hospice.
There's everything from getting car seats to, at the same time, we needed a new ultrasound machine, a significant contribution that makes us be able to just quickly bedside do an ultrasound. And in some cases, not too recently, I walked into the room, never met the woman, scanned her, and said, okay, we're going immediately to the operating room and you're going to have a baby. It was life-saving for her baby.
When patients are having difficulty getting home, maybe they came into the emergency department on an ambulance, and the Foundation's Patient Assistance Fund will sometimes help get them to their home.
We had a patient who had diabetes, and he needed help getting a machine to check his blood sugar levels and all of the supplies that he needed to do that. I reached out to the foundation to see if they could assist us with providing that to the patient, and they were able to do that for him.
The new community paramedic program is an outreach to help folks who are being discharged from the hospital, making sure they have what they need and are set up for home.
And the foundation allowed us to go from 1 community paramedic to 3 community paramedics.
People don't realize how many extra services people need that aren't covered by insurance or are not included as part of health care, but have such a tremendous impact on health.
And the foundation and all the positives that they do in the community, the different ways they serve and work together and serve the community. It's easy to get behind it more and more and support it.
Because we all live in the community and we all want a healthy place to live and work.
It's so important that the community continue to support the foundation, mostly because of how closely we at NASH work with the foundation. We're able to go and say, hey, this is what this patient really needs, and we're able to provide that assistance.
It's my sense of loyalty to this community and the citizens that makes me want everyone to have good health care.
And I could not agree more. I think we all have a bit of a duty to try to have good health care for everyone, and this is a way that we can do our small part to do that.
Dr. Warren, I think it's safe to say that Dr. Perlmutter's not going to make it.
He's running short of time.
Well, and no doubt he is being somebody's hero like he always is.
That's
so
right.
We appreciate him and appreciate all he does for our community. Is he the only just hand concentrated specialist in town?
Yeah, so he does hand, and that orthopedic group, they all have their own niche, right, or specialty. Dr. Perlmutter does hand. Dr. Hasty does trauma. Dr. Nelson does sports medicine. Actually, both Dr. Nelsons do sports medicine. Dr. Kimker and McAvoy do joint replacement. Dr. Hasty does trauma. Did I already mention
You mentioned Hasty.
Maybe Dr. Strickland does spine.
Okay.
I might be running out of folks.
And at the other Carolina Regional, they've got Dr. Martin.
Who does mainly shoulder.
Okay.
And then Dr. Singh, I think, does shoulder as well. We're a little bit more familiar with the NASH orthopedic group simply because they, outside of Dr. Kimker, they're a younger group, so they take a lot more of our emergency department call. But definitely we're dependent on Dr. Martin and Dr. Singh and Dr. Perlmutter as well when their patients come to the ER or if somebody comes in and requests them.
And it's not always the case that a community the size of ours has somebody who is highly skilled in hands.
Well, I mean, I think our community is blessed to have the various specialties. I mean, to have a hand specialist is very rare in our size community, but to have between Dr. Tyler, who's a neurosurgeon, and Dr. Strickland, who's an orthopedic, but both spine, to have 2 spine specialists, that's pretty amazing. To have 2 joint replacement specialists, 2 sports medicine specialists. I mean, you're starting to, we're sounding more and more like the Triangle than Rocky Mount. And it's very, it's a blessing to be in this community with that type of medical support. And these orthopedics, man, they get us back to work, right? Back to playing, back to work, pain-free. I mean, it's important.
I hope the hospital used you to recruit doctors because you really would do a good job on that.
Well, I'm on the Nash Foundation, so I help raise money for them.
Yeah, we saw you on the during the break.
The whole entire medical staff contributes to the recruiting process, myself included.
Well, let's jump right into the pediatric emergency services because the whole new emergency complex was built not that long ago, and there was a separate entrance for pediatric and then a separate for adults. That's going to be remodeled, correct?
Yeah, I think it's important for our community to know before we get too into the details on that. The group of providers, Wake Emergency Physicians, we're all board certified in emergency medicine. That is not the case of how the emergency room was staffed previously. We, as emergency medicine certified doctors, we are trained to see people from age 0 to 110 or however old people can live. And so you will get the same care that you would get when there was a dedicated pediatric emergency room today as when that area no longer sees dedicated kids. And to give some background on that, we had the pediatric emergency room with the separate entrance and the separate area. We actually had dedicated pediatric emergency providers as well. They were pediatricians who had done a little bit extra training in emergency care or just general pediatricians. What happened was our hospital decided somewhere in the ballpark of 2017 to not admit children to our hospital.
Right. And I can tell you that was because there were normally only 2 or 3.
Exactly.
And to staff an entire wing with nurses, complete staff, when so few. And I think the percentage of pediatric patients who come into the emergency room have to be admitted is very small.
It's less than 1%. So 99+% of pediatric patients that come to us for care are their complete care is done at Nash.
How nice.
And they go home. They're generally better, or at least on a treatment plan that they're going to get better. And they do not require transfer to a pediatric center. That less than 1%, we do rely on Wake Med, UNC, Greenville to take our children and transfer when they do require either subspecialty care or admission. But we take care of the vast majority, and I cannot emphasize enough to the community that the emergency department care has not changed at any point. Because even when we had the dedicated pediatricians over there, they generally relied on the emergency medicine certified doctors to help them when somebody came in who was really sick, whether it was procedures that the child needed or certain interventions, just because we are trained to take care of the sickest of the sick, whether you're a child or an elderly person. And as we change how the emergency department looks over the coming year, I think even when that pediatric sign comes down, families need to still feel comfortable coming to us for care and know that the vast majority of the time you're going to go home and your child's going to be better or getting better.
Less than 1%. I had no idea it was that small.
Right now we're seeing about 20 to 40 kids a day. And when we decided to take away the pediatric area, it was during COVID, the pandemic. We in 2019, we got to the point where we were only seeing 3 kids a day in the emergency room. You talk about 3 kids being admitted at a time. We were only seeing 3 that actually came in, and historically we saw somewhere in the ballpark of 40 to 50. So we're getting right there to where we were before. And we still do have nurses that are specialty trained or specialty certified in pediatric care. So for starting IVs on little veins, or helping kids get a little bit more comfortable with whatever procedure we're doing, because obviously you can't tell a 18-month-old that you need to hold still.
Right. Well, now, do you have the equipment that's sized for kids?
Yeah, so we have sizes all the way down to the neonatal in the emergency department, just in the event that somebody came in and delivered a baby before they got to the women's center. And then some of the specialty things that I think are essential in emergency care. We've got like we call it a papoose, but it's basically like a little cocoon that we wrap children in so that they will hold still. And believe it or not,
swaddling
it's like
clothes,
swaddling.
right?
Yeah, most kids feel very comfortable until we start doing what we're going to do to them. But it's we've got everything that you would have at Wake Med or UNC or one of these pediatric facilities, and that goes to the simple things like to help us do a laceration, which would be very common, but also to, let's say, supporting somebody who requires a ventilator or something more serious. We've got the ability to take care of children, even if they're being transferred, we can still take care of them, even if they're as sick as they can be.
You mentioned during the break there that you have negative pressure rooms because of COVID or something else in the back, and I think that's really neat for that safety factor to have that right there for the staff and the other patients.
Yeah, historically, people would think about negative pressure rooms for tuberculosis, shoot, when I was training in medical school, hospitals, they might have 2 to 4 negative pressure rooms, not very many. With COVID, Nash has an entire COVID wing that's negative pressure, and in our emergency department, we have somewhere in the ballpark of 8 or 9 negative pressure rooms. One's on the pediatric side, and the rest are on the adult side, or if we're not going to age discriminate, the more acute side. But absolutely, it helps keep other patients safe. It helps keep the staff safe, and it helps keep the non-respiratory sick patients that much safer when they come for us to take care of whatever they're there for.
Isn't there some expansion in the imaging services that are going to be available to the ED?
Yeah, that's actually all done, thankfully.
Good.
So now so the original emergency department, when it was designed, had 1 CAT scanner, 2 X-ray suites, and an ultrasound room. Now we have 2 CAT scanners, a much larger ultrasound room, and then still 2 dedicated X-ray suites. And for anybody who has access to emergency rooms, CAT scans happen a lot in the emergency room. So when we only had 1, you could definitely get a backlog of patients waiting for a CAT scan with everything else done, and we're just waiting for that one piece. With 2 CAT scans, we can whip you through real quick. And that's actually why a lot of this lobby type process works so well, because the CAT scan is actually directly adjacent to the lobby. It's 1 hallway away, and so we can really get everything done from the lobby triage area without you even having to get back into the main part of the ER.
Yeah, when you think of healthcare in a community, to have a total state-of-the-art, wonderful emergency department is huge for quality of life.
Oh yeah. Now, I mean, I know I look young, much younger than I am, but you won't find many ERs where you've got 60 plus individual rooms. We do not use hallway beds unless, I think in the 7 years I've been here, I've seen hallway beds used twice. And one was when we had a school bus accident on Highway 64. So we had like 45 people come in all at the same time. So you're talking about individual beds in a room. And so when you do get to the back, you have state-of-the-art individualized care that you're not going to get at your typical community ER.
Well, and you're wonderful. We've got you as our medical director, so thank you so much, Dr. Warren, for what you do. And thank you all for joining us. I am sure that Dr. Perlmutter, I guess I can't say sure, but we hope he'll be back with us soon. And thank you for joining us.